So welcome everyone to our monthly listening round. And today is a very special one, very special because I have the honor of hosting a friend, a colleague, a mentor, and someone I've known for a long time, but also the timing couldn't be any more perfect. So we have Dr. Pamela Morris visiting us from Medical University of South Carolina in Charleston. As all of you know, the 2026 Dyslipidemia guidelines released recently, and so it's just worked out perfectly that this meeting that was planned a long time ago, it happened to coincide with the release of the guidelines, and so how fortunate are we? So Dr. Morris is the professor of medicine and cardiology and the Paul Palmer Chair of Cardiovascular Disease Prevention at NUSC. He's the founder and director of Seinsheimer Cardiovascular Health Program. Obviously, she's a fellow of the American College of Cardiology, and so happy to have my president that's lost in. So thank you, Dr. Williams. And he's also a member and fellow of the American Heart Association, the American Society of Pediatric Cardiology, the FACC, and of course, the National Association. He's served as vice chair of the ACC scientific section in 2019 and 2020, and the chair of one is 2022. And I did go to those meetings, and they were phenomenal. So thank you, Jen, for all the work you've done in the past, not just in that regard, but each of you in general. She's taught me so much, being in the board of trustees, just the knowledge this morning. So, thanks there for all those insights. She's also probably a trustee on the board of the American College of Cardiology, and has been associate editor of Jack, and it's very important to have a big role for Jack is to try to get all the best and most to understandably associated and
wonderful. Blessed role. One journal. Tim, have you ever served on more than one journal?
Yeah, but I've had as an associate.
It's just
editor-in-chief.
I do just one journal and lost it for a lot of work. Well, it's really nice, Dinesh. Thank you so much. It's really wonderful to be here. I was really looking forward to it. I was actually born and raised in Ohio, just right over the river. And when I flew in, it was so exciting because it just looks and feels like home. So it's really nice to be back. So what I wanted to do today too is to go through some of the top messages from the lipid guidelines, but also provide a little bit of perspective in terms of why the guidelines, what were our thought processes behind some of the things in the guidelines, give a little bit of an inside road, and then hopefully you'll also understand. So these are the guidelines. Just to cover, Roger Blumenthal was actually the chair, and then we had an amazing group. You may or may not recognize some of these faces. We had a writing committee of only 3 people. This is one of the greatest achievements in my life, is you have to achieve consensus from 33 cardiovascular clinicians. In addition, you also have to achieve consensus from there were 32 people on the peer review committee who provide feedback as well. Then all of the sister societies have to approve guidelines. To say that I now specialize in consensus building is an understatement. So what I want to do today is to help you formulate management strategies for patients who have dyslipidemia all across the cardiovascular risk continuum. Have you be able to integrate evidence-based LDL cholesterol, non-HDL triglyceride, as well as ApoB goals into your clinical practice. And this helping counsel patients on the changing recommendations. And I'm really sure for you guys that you are very likely to be, when you're counseling patients, when guidelines change, a lot of why, especially because these guidelines became more aggressive. And I get this question all the time. I don't believe in this because the normal cholesterol used to be 300, then it was 200, and now it's 100. You guys just make it up for the for pharma companies. So What are the most important things you need to know about the new guidelines? So the first thing I wanted to share with you is, what was the rationale? Why did we write the new guideline? The first thing is, it was time. It had been 8 years since the previous guideline. Also, we had approval of, I think it's 5 new agents, bempedoic acid, inclisiran, evinacumab, and HoFH. And then most recently, in December and January, we had olezarsen for severe hypertriglyceridemia and plozasiran subsequent to that. We had the results of the CLEAR outcomes trial demonstrating the benefits of bempedoic acid in statin intolerance. We had a brand new risk calculator that is far more precise and accurate to use. And also, what we really wanted to do, this was a real sticking point for me, we wanted to change the name of the guideline, because it's ridiculous to have a separate guideline for LDL cholesterol and leave out triglycerides and leave out ApoB, leave out lipoprotein (a). So this guideline, we renamed it so that we were inclusive across the continuum of lipids. Here were the goals of the writing committee. These were Pam Morris's personal goals. Number one, wanted it to be transformative. We didn't want to just take the old 2015 guideline and just, regurgitate them with 1 or 2 minor changes. We had an opportunity to truly be transformed. There are a lot of controversies about the 2013 and the 2018 guidelines. We wanted to create a living document, so you should know now that guidelines are being surveilled on an annual basis for the need for potential update in the next year. We wanted it to be clinically useful. That is, how can it reflect how we actually practice on a daily basis? And then this is a big bugaboo for me. What I really cannot stand, I never want to see another article written on what are the differences between the European and the American guidelines. It drives me crazy. It's not fair to clinicians and it's not fair to patients. Why? Because if we can't agree as experts around the globe what the science is behind the guideline, why should patients trust us? Why should cardiovascular clinicians trust us? So really it became important to think about how can we harmonize global guidelines for more effective implementation. So with that preamble, let's go into the top 10 take-home messages. First of all, this is really a major theme. This is what the media has picked up on the most. Treat earlier, lower, or long. Now, the earlier comes here. There are 2 things that bring us into the earlier or longer and lower. One is that we know that your total plaque burden is approximately proportional to your cumulative exposure to LDL cholesterol over a lifetime. And we know that people who have lower LDL cholesterols from birth for a lifetime reach that threshold for atherogenesis at a much later stage in life than people with FH or others that start out with higher or intermediate level of LDL. So the real thing we want to do is not continue our sick care. The sick care model is to wait until someone has manifest disease, initiate aggressive lipid-lowering therapy, and here's all we do to bend the curve. We barely bend the curve to delay further events. What we want to do is be sure to initiate lipid-lowering therapy, lipid-lowering therapy or lifestyle intervention as early as possible, because now we can truly bend in disease. Now, the second reason that we're going to come to here in a minute is for the earlier or longer comes with the new prevent calculator. We'll talk about that in a moment. So if we're going to start earlier, we need to be sure that we screen. Now, the first one is not change, which is by age 19, all adults should be tested for a lipid panel at least every 5 years if there are no risk factors. You would test more frequently up to an annual basis if there are other risk factors present. But we wanted to reiterate the guidelines in children in this earlier, lower for longer model. Are you afraid to come up front? Okay. I did shower and where to right. You're welcome to one book. But the children guidelines have been around since 2011, but nobody pays any attention to them. So what you're supposed to do is universal screening in all children between the ages of 9 and 11 before they hit puberty. And if the family has either premature cardiovascular disease or severe hypercholesterolemia, children should be tested beginning at 2 years of age. So reiterated those because it's so important. Now, here is the other reason. We now have data, this for earlier loan, the prevent ASCVD equation now extend out. We have data down to age 30. Previously, that was like it was 45 is where the pooled cohort were. So now down to age 30. Now, the estimates for this in terms of risk are a little bit lower. There is greater precision and accuracy with the prevent equations. Why? Because instead of being derived in about and validated in about 45,000 patients, this is derived and validated in 6.6 million individuals. Again, all the way down to 30 years of age. The new equations predict total cardiovascular disease, heart failure, as well as ASCVD. So you have to be careful. Remember when you're using the lipid guideline and predicting risk, when you go into the prevent equation, you need to toggle to be sure what you're doing is predicting risk of ASCVD, not total cardiovascular disease or heart failure. Now, remember these prevent equations have all the traditional available markers of risk, but you can optionally add in hemoglobin A1C, urine albumin ratio, or zip code as a reflection of their, I forget what SDI stands for. No, it's not SDI. It's Social Deprivation Index is what that stands for. Social Deprivation Index as a reflection of social of health. But those are optional. So you can use the prevent equation if you don't have that. Most patients do know their zip code, but if you don't have the other, it's no problem. So how do we use the prevent equations in practice? So the first thing you do is you use them to calculate the risk. So low risk is less than 3%. Borderline risk is 3 to less than 5%. Then up to 5 to 10% is intermediate risk, and then 10%. Now, then you want to go, once you've calculated, you then do get a recommendation for what is recommended. But if you would like to, in individuals, specifically those at borderline risk, this is where you can use you want to personalize it with risk enhancers and reproductive risk markers. So what are these risk enhancers? These are things that you're familiar with. There are demographic, genetic, and family history information, particularly a higher risk ancestries like South-Asian or Filipino. Clinical conditions like inflammatory diseases, DKM syndrome, and we'll talk about reproductive risk markers, and then biomarkers like hsCRP, triglycerides that remain elevated, a persistently high level of LDL, and lipoprotein(a). So those are the risk enhancers. And then, of course, all of these reproductive risk markers. I hope all of you now include a reproductive history in your general history for women. And we're all familiar with preeclampsia, gestational diabetes that are not a lot of women don't remember the age of menarche. Most of us remember the age of menopause because where things went dark, but we do remember it and PCOS. Now, the next thing you can do, and this is another place that had a lot of controversy picked up by the social media. In individuals at borderline or intermediate risk, so somewhere between 3 and 10%, 3 and 10%. If a patient, I want to note that both of these groups have a recommendation that they will benefit from statin therapy. We'll talk about that. But if the decision, either on the basis of the patient or the clinician, remains uncertain, we already know they'll benefit from treatment. But if they say, I really am not sure I want to go ahead with this, despite that's when calcium scoring comes into play. Now, I say this because there was quite a misunderstanding on social media. In particular, some of the folks thought we were recommending universal calcium scoring. This is when the decision to treat is uncertain. Now, calcium scoring can be useful for other reasons too, but just to point that out. So the third take-home point, again, then, is that it can improve the risk assessment if you are uncertain. And as you all well know, being trained by Dr. Cara, is that both the absolute amount of calcium as well as the percentile, with the absolute telling you the total atherosclerotic plaque burden, and the percentile telling you relative how premature is the disease relative to their age and ethnicity-based percentile. Now, what about CAC-guided scoring? Again, here, if the decision to treat is uncertain, if calcium is present, then you will treat. If it is not present in those individuals, they can opt to defer therapy. So in this guideline, this is a new recommendation. We now have specific goals of therapy based on the actual absolute calcium score. So again, we have less than 100 and less than the 75th percentile at LDL cholesterol goal of less than 100. When our 100 or to almost 300, essentially 300, your LDL cholesterol goal is less than 70. When it's 300 to 1,000, the goal is still less than 70, but you have an optional LDL cholesterol goal of less than 55 milligrams per deciliter. And once you're above 1,000, it's less than 55. It's an MI risk equivalent. Then we have new recommendations for the first time for incidental calcium scoring. When you guys are doing consults and you're seeing patients and you see someone and they're asking you a question about chest pain or whatever, always look to see if they've had a CT or a lung disease, or if they've had a CTPE. For those, again, if you see calcium happenamonic graph coronary atherosclerosis, that's the only thing that does it. They have atherosclerosis. Now, the one thing you need to remember is if you don't see any, that doesn't guarantee you there's none, because these are ungated. So keep that in mind. It on a non-gated scan, you can't use it to defer statin therapy. You need to have an actual calcium score that's gated as well. Now, let's move on to primary prevention. After you've done the calculations, the personalization, etc. Remember that even low-risk individuals, so someone comes out at low risk, less than 3%, technically, that you would say, okay, well, they don't need treatment, except in 3 groups of people. We know that even low-risk individuals can benefit if there is a very high LDL above 160, if they have a very strong family history of cardiovascular disease, or they're 30 years, their long-term risk calculates out greater than 10. So keep that in mind. Now, for those at intermediate and borderline risk, there actually are recommendations that they will benefit from statin therapy. Plus, first, for those at borderline risk, there's a class 2A recommendation, meaning it is reasonable, can be beneficial in folks between 3 and 5%. And we have a class 1 recommendation for moderate to high intensity statin therapy in individuals who are at intermediate risk between 5 and 10%. So both borderline and intermediate risk. For high intensity, for high risk patients where the risk is about 10% or greater, their LDL cholesterol goal is less than 70. This is new. And class 1 recommendation for high intensity statin, but in addition with an LDL cholesterol goal of less than 70. Whoops, I did that. And if needed, never before have non-statins been recommended in primary prevention. Now we do have a recommendation for ezetimibe if you cannot achieve a goal less than 70. And that's a class 2A recommendation, and class 2B for may be reasonable in high-risk primary prevention. Point number 5, the LDL cholesterol and non-HDL cholesterol goals are, you guys were all too young to remember, but 2013 to 2026 were challenging years because they took away LDL cholesterol goals and people were really struggling. Clinicians really didn't know when to implement non-statin therapies, or when to intensify statin. So we brought the LDL cholesterol goals back. Now, stent reduction still remains a priority, but LDL cholesterol goals are now health and decision making. A couple of things I'll just point out for you guys. They're important. I don't know if you know, what equation does your institution use? Friedwald. So we still did too. So the Friedwald equation is no longer which is the LDL plus non-HDL plus triglycerides divided by 5. And then you calculate the LDL from that. The Friedwald equation was derived at a point in time where the normal total cholesterol was 300. It is derived in data, not a lot of data back in that era when the population forms were much different. And now that we can achieve very low levels of LDL cholesterol, plus we also have more high triglycerides, this equation no longer holds accurate. So we recommend that you use the Martin Hopkins or the NIH. And Dinesh, you should just know that this just changed for me after it took a year of pushing our labs to calculate it and report it in FACC the proper way. So, but I only did it because I was this and I had to, but it can be done. It can be done. We use the NIH because it's free. The Martin Hopkins. So anyway, and then also we don't recommend, everybody should have a non-HDL. We don't recommend direct measure of LDL, not standard body. Number 6 is using ApoB. So as we know, there may be residual lipoprotein-related risk, even after you believe that you have your LDL cholesterol at goal. Non-HDL is a reasonable surrogate for it initially, but there can be discordance between LDL, non-HDL, and ApoB. In a battle between the three, risk most closely tracks with ApoB. What we recommend is that you get to your LDL cholesterol, your non-HDL cholesterol, and then you verify that you've achieved adequate risk reduction. And this is particularly in 3 groups of people: anybody with high triglyceride, anybody with diabetes, and also those people who have high risk CAD patients. You get them down and you think you've got them perfect, got them at an LDL, let's say, let's pretend your LDL also see 50, you've got them to 54. They got a little bit of triglycerides and you snag an ApoB and it's actually stuff. They need further intensification of therapy. So ApoB is recommended. Now, when you look at goals here, pretty easy to remember ApoB goals of several one thing. In primary prevention, if your LDL cholesterol goal is less than 100, your ApoB goal is less than 9. That's the only way they're different. For everything else, if your ApoB goal is less than 11, and if your LDL cholesterol goal is less than 70, your ApoB goal is less than 70. If your LDL goal is less than 50, your ApoB. So pretty easy to remember. Now, point number 7, take-home message number 7. We recommend WOW to measure lipoprotein(a) once in a lifetime. Now, that is because this is primarily a stable, genetically determined biomarker of lipid. Now, we're all aware, another point of controversy in these guidelines is why are we measuring something that we can't treat? Well, the same could be said of HDL, but HDL's in all equations. We can't treat it, but we measure it for risk assessment in the prevent equations. And lipoprotein(a) is the same here. It is closely aligned with vascular. So what you're doing it for now is risk evaluation. And if it is above 125 nanomolars per liter or 50 milligrams per deciliter, it should be considered a risk enhancer and use personalized risk, as we talked about before. When an Lp(a) is above 250, it doubles the risk. At above 125, it's about a 40% relative risk in some. Now, what are the approaches with elevated Lp(a)? And you can see here that for all individuals, it's a risk enhancer, and you should be aggressively controlling all other risk factors. The one caveat here that we did include for patients who already have clinical ASCVD, and they have not met their LDL cholesterol goal, that could be the thing that causes you to choose between ezetimibe and a PCSK9 monoclonal antibody. You get somewhere between a 20, I've seen a little better, sometimes up to 30% reduction in LPA. Probably may not be enough to be clinically significant. Most of the new agents being studied obliterate Lp(a), but this is a reason to choose. Okay, what about some special considerations in therapy? So there are 3 groups of people you should remember that get statin therapy regardless of their baseline cholesterol. Who are those people? Diabetes, patients with diabetes, patients with chronic disease, stage 3 or stage 4, as well as patients with HIV. So let's look at those. So first of all, let's talk about in diabetes. Keep in mind, when you look at London, I know. So what about young folks? It is always been in the area of conflicts. We don't have a lot of data in patients with diabetes between the ages of under the age of 40. We just don't have a lot of data. So what we do is look for risk enhancers. Have they had diabetes for a long time? Or do they 10 years or more, 20 years at type 1? Do they albuminuria? Is their renal function impaired? Do they have evidence of microvascular disease or peripheral vascular disease? If so, then these patients, even young individuals, have a class 2. It is reasonable to treat them with some moderate intensity statin therapy. Now, what if an individual what if an individual does not have weight blood? Oh, is this right? So what if they're young and they have no diabetes-specific risk enhancers? They're just young. Then these folks default to just calculating their prevent risk and treat based on. So risk enhancers present, consider treating those risk enhancers, not then you just default to the equation. Now, both older from 40 to 75, all of them qualify for moderate intensity statin therapy, all patients with diabetes. But what you do is you also calculate the prevent ASCVD risk, because if that is elevated, then you would consider intensifying to high-intensity statin. So if they're at low risk, their goal is less than 100. If they're at higher risk with the condensed equation, then their LDL must hold less than 7. Also remember, this is one of the groups you would have ApoB goals. This is a group that will benefit. And also you can then, if you need the lowering patients with diabetes, can have ezetimibe or PCSK9 monoclonal antibody. Those are 2A recommendation. And then if you, to be actually the monoclonal. And also then you may also have a 2B recommendation for IPOSIC and FO based on the REDUCE-IT trial in with diabetes. And what about older adults? This has always been older adults with diabetes. This has always been an area of controversy as well. This really is their decision in older adults. If they're doing well, don't have ASCVD, but they have diabetes, you can engage in shared decision making. If they're, 75 looks a lot different than it used to look. These days looks a lot different. And we do all kinds of things in older adults. We put in bouts, we put in everything. What the heck is wrong with preventing ASCVD with some statin if needed, Now, CKD, again, I've already said stage 3 and 4, at least moderate intensity statin based on the SHARP trial with or without ezetimibe is great. With clinical ASCVD, these patients automatically high risk, less than 55. And if somebody's not progressed to dialysis while on statin, it may be reasonable to continue their statin. You don't have to be in HIV. This is based on the REPRIEVE trial with pitavastatin that demonstrated benefit. It focuses in a stable HIV regimen, as long as there's no problems with drug interactions. This is a REC class 1 recommendation for statin therapy with HIV. Cancer, folks with cancer, active cancer should be treated the same way that folks without cancer are treated, particularly in today's world, and so many of us cancers are treatable. Continue their therapy just the way you would. And there is some emerging information on the benefit of statins for preventing anti-FASPC pregnancies. No, the FDA took away the black box contraindication for statins in pregnancy. So if you've got a high-risk woman with ASCVD, again, in the context of shared decision-making, you may consider continuing statins in pregnancy. There's never been any evidence of cancer-causing any side effects with statins. And in fact, the database of women with FH who accidentally got pregnant while on statin has shown no harm to the fetus and no risk to the mother. So inflammation, we also now have a class 2A recommendation now that statin therapy is reasonable with anyone with an HSCRP2 or above. Now, what about goals? Let's talk about established. So now that goals are back, what are the new goals for ASCVD? For all of those patients at very high risk with ASCVD, it's less than 55 milligrams per deciliter. Now, we did maintain this category of patients with ASCVD very high risk. Who are these people? They're few and far between. There's still too many of them. These are the people who get a calcium score. They get referred for a CAL. Someone finds a lesion, stents it when they're asymptomatic. Now they have a stent. They didn't have other risk factors. They were a victim of ocular stenosis. Those are folks who we felt were potentially in that not at very high risk. They don't have multiple additional risk factors. They got it based on an unnecessary procedure, essentially. But anyway, there aren't very many of these, but we maintained it. Now, I have to tell you, the guidelines were approved and authorized and finalized before the results of the Vesalius trial, and we'll talk about that at the end. which was published last November. So we'll talk about the implications for that. So here again, this is for secondary prevention, ApoB goal and LDL cholesterol goal less than 55. You can give them ezetimibe, a monoclonal antibody. You can also start 2 drugs at once. So the European had this recommendation for with an acute coronary syndrome, you would automatically start both ezetimibe and a monoclonal antibody at the time of the event. We did this a little differently, which is that you may start both if you far to get to your goal, or you can start one if you don't very far to get to. Bempedoic acid is a new recommendation based on clear outcomes, and inclisiran. We still reserve inclisiran as a second-line PCSK9 monoclonal antibody because the company yet completed, but this as Ryan, yes, it is Orion 4 is has completed, which is delayed. I thought for now, but it's still. What about hypertriglyceridemia? Just some key points. We're not going to go into great detail here, but remember that lifestyle management is always the foundation for hypertriglyceridemia. We do not have drugs for hypertriglyceridemia that have been shown through triglyceride line to reduce cardiovascular events. Fibrate has never been shown to reduce cardiovascular events. The omega-3s, depending on what you believe about reduce it, but strength. So reading statin, really how we should be treating patients with moderate hypertriglyceridemia. These patients benefit from a registered dietitian nutritionist. And again, this is a group of people that benefit from an ApoB goal. We're not going to go to the table in the guidelines, but as triglycerides go higher, the aggressiveness of your dietary recommendations, particularly in added sugars, total fat, and alcohol, all get more aggressive and the triglycerides are higher. All benefit from weight management is overweight, and all benefit physical activities. You can get dramatic reductions in triglycerides with lifestyle alone. Now, drug-wise, really essentially, for anybody with triglycerides less than 1,000, your initial drug is statin therapy. Lifestyle and statin for these people. Again, if you have more severe hypertriglyceridemia of 500 and above, you can use these drugs to technically prevent pancreatitis. Again, I will tell you that fenofibrate and the omega-3 fatty acid have never been studied to reduce the risk of pancreatitis. We prescribe them, presumably lowering trigger, but they've never been demonstrated to do it. On the other hand, in possible severe familial chylomicronemia syndrome, where these patients have severe hypertriglyceridemia, both olezarsen and plozasiran have now been demonstrated to reduce the risk of pancreatitis. So we finally have 2 drugs that actually do that. So a couple of key takeaways. These are just drugs, severe hypercholesterolemia, recommendations for every drug. Bring the numbers down. You can get anything to here. And the goals are based on whether or not they have ASCVD. So if they don't have any other risk factors, they don't have ASCVD, their LDL cholesterol goal is less than 100. If they have risk factors of glomerular calcium, it's less than 70. If they have ASCVD, it's less than 50. So the goals are the primary thing. It's different. Homozygous FH, give them everything, but they may also be candidates for the new ANGPTL3 inhibitor, which is evinacumab. That is a newer agent, again, inhibits ANGPTL3. The reason that drug works is because it's independent of the LDL receptor. So remember, every drug we talked about up till now works by increasing the number of LDL receptors a patient has on their liver cell. But in a patient with HoFH, they don't have functioning LDL receptors, most of them. So therefore, these drugs are only marginally effective. Evinacumab doesn't have anything to do with the LDL receptor because LDL. So great drug. Lamidopide, another one that inhibits LDL production through a non-receptor independent pathway, and LDL apheresis. Do you all have an LDL apheresis? Yeah, there aren't many of them left with all the new drugs. Just final thing here, know the things that aren't of benefit. So all this advanced lipoprotein testing, you'll see patients come in with their particle sizes. It's all based on particle number, which is reflected in ApoB. Knowing the number of small LDL particles or the size of your small LDL particles is not correlated with risk. It is the number of atherogenic particles as reflected by ApoB. There are no dietary supplements that have been proven to be of benefit. Coenzyme Q10, it has not been shown to be beneficial. And routinely measuring CK and liver function tests or hepatic transaminases, not recommended routinely. It should be used when there is a concern that these may be abnormal. And the final thing, how am I doing here on time? Okay, 3 minutes. I can do this in 3 minutes. So I remember I mentioned the Vesalius trial, and I know you guys are all in the training part of things, so I can understand that you guys don't spend a whole lot of time thinking about every new trial that comes out. But Vesalius in the prevention world is a very important study. So what they did is they took over 12,000 folks who can technically have atherosclerosis or even have had a stent, but no prior MI or stroke. Or they could have what they call high-risk diabetes. So that's long-duration daily insulin or microvascular disease. You could also get in with a high calcium score, is another way you could get into this. So here's what they look like. About 8,000 folks got in by having, quote, atherosclerosis without a previous MI or stroke. And another 6,000 or so got in by having high-risk diabetes. And then what they did is they randomized them to their regular medications plus evolocumab, or their regular medications alone for lipid line. And what you saw here was a 25% reduction, relative risk reduction in 3-point MACE, and over there, 19% reduction in the 4 MACE. Now, they also then subsequently looked at patients who got in with diabetes alone. Oh, and by the way, I should go back and just mention here that I don't have this on the slide, the median achieved LDL cholesterol level in this trial is 45 milligrams per deciliter. 45 milligrams. And these people, their baseline LDLs were that people 1.11.12. So big, nice drop with evolocumab and significant benefit even in diabetes where on treatment with evolocumab 45 milligrams per deciliter. They had a separate sub-study. The benefits were actually even greater in the folks who got in with high-risk diabetes, relative risk reduction of 31%, is the plus point made. So what they did allow us to do, so that's pretty disappointing to us. How this all played out was the cell trial, the guideline was approved in the beginning of November. All societies that signed off on it, the whole thing is good to go. I get asked if I would be the discussant at a late breaker in the opening session at AHA in the middle of November. I get the trial. I am like, oh my God, everybody needs, all these patients need an LDL cholesterol level of 55. I'll be doggone, it was too late. It was just too late. Guidelines done, both, nothing you can do about it. So I was very lucky that what they did let us do was write an accompanying evidence editorial at the time the guideline was published. And what we said in this editorial was that future updates to the guideline should include a single pathway of care such that all patients with atherosclerotic cardiovascular disease should have an LDL less than 55 milligrams per deciliter. And we said that also patients with high-risk diabetes should have an LDL cholesterol less than 55. Now, this is not an actual revision of the guideline, but it certainly lets the world know that. So that's what we were able to do. So hopefully, I hope that this helps you think about management strategies for your patient, that it gives you a little background into how we thought about guidelines and what we were trying to achieve, why we made the changes we made, and maybe we'll give you a little more confidence to try to count the patient on why do we keep going lower. Certainly the salience is one I bring up all the time. With that, I'll end, and I'm happy to open it up to questions. It's pretty good. Anything besides standing up on the time? Any questions, y'all? Yeah, go ahead. Yeah. Do you mind, I know the guys know who's Dr. Williams. You guys, do you mind?
It's a girl's name, but it's okay to make it.
No, I just being signed. If you don't mind if you supposed to name you, I'm sorry.
You thought it's irrelevant, I think.
Oh, Sharon.
Yeah, she made the publication about how women are called by their first name and guys are called doctor. Mm-hmm. And so I purposely never do it. So it's a girl's name, but it's fine to call.
Once you are with people and you get to I even have my fellows and residents call you by my first name, only in the sense that I feel like we are a team. Now, when I say we're a team, I'm not in the hospital lead that might take care of these sick people. You guys are taking care of these sick people. And I feel like I cannot do what I do without having you do what you do. So I tend to be more casual with first names. That I feel like it builds a better team experience.
It's a good point. I still do it. It annoys my friends when I call them doctor.
Well, then you can call me Pam. I'll be insulted. So there you go. All right. Well, then just don't call me anything.
I really call you out for something that you didn't say that I believe is the most important thing that came out of this guideline. In 2017, I was co-author of the prevention guide, pushback on making it completely vegan.
Mm-hmm.
And the pushback was, you have to finish, American Heart Association and Redomet showed no decrease in heart with Mediterranean diet, no change in cardiac death, no change in overall, but it did decrease stroke. And their comment was, we are a stroke organization and we have a journal. So you lose Dr. You guys, table 4.121, okay, it's recommending a completely plant-based diet. That changes about 79 diseases, about 80% of them do. I actually had a back of the envelope calculation by ChatGPT that said it would cut our healthcare expenditures in this country by 2/3. So congratulations for that. Knowing that two of my colleague trainees, Blankstein and Chianos on there were hardcore vegans and pushing it for it. But I want to say that that's got to be the most important thing. And I quoted essentially 10 times. So thank you. So that was the comment. Can I just ask a couple of questions? We really struggle with EC full cohort equation versus prevent, is what we're doing with it is going into the West End and doing finger sticks. And I Abbott ISTAT for EGFR to get a creatinine doesn't work reliably. And I checked with every radiology department who's doing it all the time, going to care cholesterol, they're drawing blood. You just can't do that in it. No.
So, I think this is really important in the sense that low resource setting. What I just delivered to all of you is it are the guidelines, evidence-based guidelines for high resource setting. Tim, you do as well. Travel the world talking to people about high cholesterol. Half the countries can't get the drugs that we get. Some of them can't, no approval whatsoever for measurement of lipoprotein(a). Can't be done. ApoB, half of them haven't even heard of it. What I have given to you is how you treat in high resource setting when you have access to all of these things. Absolutely, I would have no trouble whatsoever defaulting to the full cohort equation in a low resource setting because it does include eGFR as in the basic measurements, meaning you've had a CMP measure. Now, in high resource settings, people are getting that. Low resource settings, they're not. And so I'm actually working on a document, a global collaborative document right now for managing cholesterol based on low, middle, and high income countries and how to customize evidence-based guidelines based on resources, particularly in low resource setting. You do what you need to do. It's slightly less precise. It's slightly less precise, validated in a lot less people, but it did okay. Remember, the equations are just a starting point for a shared decision making. So you get a rough estimate, you go from there, you decide how to personalize and happily.
And it tends to be higher census data. But two real quick questions I know that number one is that, and it's more of a comment than a question, and I struggled with it when we were writing the 2017 guide. That was 20%, now it's 10%, above which the coronary calcium isn't recommended as a starting for statins. I use it regardless. Anything that a person who's a 5% now, that would do it because coronary calcium gives us location and it really changes your management completely.
So also going back, this is a good teaching for you guys as well. Calcium scoring is used not only in risk assessment, but many of us, and it's recommended guidelines now also for goal attainment. So there are folks, because, as you saw, we now have that table that shows you based on the amount of calcium in the percentile, here's your goals will differ for care. So it's useful not only in risk assessment, but for goal setting.
My last one is the coming back of non-HDL cholesterol. We see a little bit, be honest, Copenhagen and Ganhart show that IHDL increased mortality. It's a U-shaped curve, which means that...
You're saying HDL, not non.
Here's what I'm saying. That is, the HDL, if it's 110, that's a high risk thing, and we're subtracting it to make a non-HDL.
Good point. Very good point. I don't remember addressing that specifically. It was just included. It's really included because that's few and far between. But we all see them in practices. There's people with very high HDLs who still have disease. We see them all the time. We're really thinking more on the bell-shaped curve of people with HDLs in the range where it makes sense to use it for a non-HDL calculation. I think that's one of those things where I also always say, remember we used to do total to HDL ratios. We used to do ratios all the time. With non-HDL, you're using a bunch of numbers and shifting them around to calculate something else. When in reality, if you just looked at the HDL and you just looked at the triglycerides and you just looked at the LDL, you would have something you could deal with. So I think your point is well taken, and a good teaching for them is that when you get at the extreme high levels of HDL, it's not necessarily protected. Let me open it up to you guys. Maybe you have a question, or if you're online and you have a question, I think there's a mechanism as well. Do they just unmute and ask a question? Anybody who's online, if you just want to unmute can ask a question. I'm happy to entertain you.
Question two.
Okay. Yes, Peter.
Actually, a couple of questions. Too. So going back to the discussion about HDL, that point's a good one. Primary HDL, use protection about 1 year or so. But then the total cholesterol minus the HDL counts. The HDL is going up, the total blood sugar is also well, that's it. It's a non-HDL actually does capture the ELDL. That is correct. That's the ratio. Correct, the rest of them. Yeah, you're right. That does. Just a philosophical note on the guidelines, which I find really encouraging. As you mentioned, the 2013 guidelines were so pure and science-driven that they forgot on the guidelines also that drive the population health documents and documents that peers look at. So while I see the furor, the groups on social media, here's the evidence that accountants who are more than 1,000 deserves an LDL of 55. Here's the trial that this benefited people. It's not there, but we've extrapolated. This is risk is staying the second. So hence you should treat people at risk.
So I said, Vesalius is now our. That's at least.
But Vesalius was there, so. But I do think that guidelines need to incorporate that for the opinion when it matters to the population health.
And certainly we did get, there are three things that really got a lot of run up in that guidelines. One is a mistaken impression that we were recommending you have. The earlier lower for longer was based on people staying years, and all we wanted to do is put more people on statins and life our buckets from our pharma. All the honoraria I get from pharma would be zero. And the third thing was what we were just talking. What did you just say?
Health scoring data.
Well, they
deals with out.
This data. Hornet, I had three things I was thinking. The controversies were the linear lower for longer, the calcium scoring, and I can't forget it. It's a point
instability.
Yeah. That's one of them. That's earlier, lower for longer, and the calcium scoring plus one. I can't remember. I had points I was going to make. You get 2 out of 3, and that's all you get. That's all you're going to get.
I did have one other question. You mentioned about the importance between European and American class. Right. Majority of the document is important. Think of 3 areas. Nuance. You mentioned strength versus respect. The Europeans said 2-way, which they feel strong that IPE echoes of pentathlon is beneficial. And strength was not done just for IPE, it was done combination. So what are your thoughts about, emphasizing prosopentanol in diabetics or patients with coin reduction first because triglycerides are off? That's one. Second, they actually went for less. They went for less than 4.
Yeah. So, as my some of my fellow colleagues, I know Tom Dayspring is one of them that sort of feels like I do as well. I feel like saying less than 40 is getting out a little bit over their skis on this one. Fourier and Odyssey did have a median for initiating therapy. It was a median on treatment of 30. What we have is 55, as if you remain above that, you should initiate a PCSK9 inhibitor or a ezetimibe, which means that you will achieve an LDL cholesterol of 30. It's 2 different strategies of getting there. Saying that everybody has to get to below 40, and saying that at 55, if you haven't met your goal, start a PCSK9 monoclonal antibody. It's the same endpoint with a different strategy for how you justify it. And they do actually even say that, it's a little bit over the skis in terms of evidence documenting that in a randomized trial, you should do that. So I think, for example, we should be able to do, if you say that, is you should have a trial that says that you're above 55 and we'll randomize people who don't get, if that would need to be done, and it wasn't. So we get to the same endpoint with a little different strategy, if that makes sense. Which is why I don't break. Yes, ma'am. So we now give it, bye-bye, thanks for coming. We now give that a 2A or 2B, I don't remember if it's 2A or 2B, that they may be considered for statin therapy if they're going to be choose the anthracycline. I don't do cardio-oncology, so I can't honestly say, but there is evidence to support that. And a lot of the oncologists where I work are using them. Yeah. So we are seeing them use them. Yeah. Did you have a question?
Like we're looking for a lipid.
Okay.
So is there medication?
Wow. That's a great question. So for severe hypercholesterolemia for kids, most of them are foods starting at age 8. One or two of them one is at age 10, but it's subtle difference. Most of them are age 8. And some of the newer methods in homozygous FH, evinacumab can be started as early as age 1. I think lamivudine is age 2. But so children definitely. The other thing, sometimes I do wish I was a pediatrician, pediatric cardiologist, because kids never complain of side effects on statin. Largely, it seems to be this confirmation bias. All my patients go online and say, I look to find out. I see it all over the internet. I am going to get muscle. It's like 5 to 10% of people, and I can go on the internet and find someone to tell me that the sky is purple or something that actually, the sky is green. I can find that on the internet. Literally, I bet if you right now Google the sky's green, I find the northern light. But anyway, it is. What's your big question before I what? Oh yes, they did. I can point it for us, Jim. But kids never complain of side. They do incredibly well. Now, adherence can be difficult in children because I know I've got a couple of high school gentlemen, both of them actually play football and don't like being on drugs as a football player. It just really doesn't jive with their image. And adherence can be a problem with kids, but they don't have side effects. What's the goal? So, there are separate FA guidelines for children, and they're generally more conservative. I think usually they're like less than 130. If they've got other risk factors, it's under 100. And obviously, if they've homozygous FH, it's just, that generally is as low as you can possibly get them, and sometimes you can't get them very far. No,
If diet.
Well, it has multiple diet, so it's recommended. It has the alternatives. The recommendations are as plant-based as you can go within the context of a Mediterranean diet, a vegetarian diet, or a vegan diet. So the fact that we even mentioned vegan wins points with Dr. Williams. So, okay, I don't want to keep you guys too long. Thank you all for coming. I know it's really important. You lost the blog. Those online, you missed some really great Chinese. But you juggle and update it.